I'm going to share the screen and go to our weekly updated slide set. And Dr. Lick is going to join me in just a minute. But just to remind everyone, if anyone hasn't seen this yet, don't put your name and email in the chat, but do email it to covidcme.dhhs@maine.gov. You should be getting a evaluation form from Gail Began at MMA, and then a CME certificate that you can fill in with the number of sessions you've attended. We do not have any commercial disclosures or relationships to disclose. We are going to continue working through different topics, and this week, both today and Friday, we'll be talking about viral variants and new vaccines, also in the context of some of these emerging variants. And with that, I'm going to turn it directly to Dr. Lichty.
All right, thank you very much. I'm going to ask you to help me advance the slides, I think.
Yes.
So thanks for joining us this morning. I've been asked to talk about viral variants / vaccines, including new vaccines. I'm going to, I tend to have a hard time avoiding too many words, but I'm going to try to avoid too many words so that we leave time for questions. So briefly on variants, I think most of you have probably read a lot about this topic so far. Viruses, like anything else that replicates, make mistakes at times. And the more viruses replicate, the more you get these genetic typos. So we expect basically molecular evolution over time. And sometimes that's a single error. Sometimes it's a cluster of errors that is concentrated in a specific region of the virus. And the biggest concern so far with SARS-CoV-2 has been certain variants that arise as a result of multiple mutations concentrated in the S or spike protein region. As many of you know, this is the part of the virus that binds to what we call ACE2 receptors in the nasopharyngeal and mucosal surfaces of the respiratory system in humans. And that's how these viruses infect us. So mutations that result in an enhanced ability of the S protein to bind to the ACE2 receptor have an advantage. And in the B117 variant that was first identified in the UK, this appears to be what happened and appears to have translated to better ability to be more infectious and more transmissible. In terms of molecular surveillance for variants, the efforts at that were small, I think it's fair to say, in 2020. But in the late spring, early summer of 2020, the first sort of significant variant that led to a real shift in what was spreading epidemiologically in Europe, for example, was identified. That variant became dominant fairly quickly, but did not seem to result in any significant differences in terms of severity of illness or spread. However, in the fall of 2020, the B117 variant was identified in the UK. This is the example of what I just described, a virus that had what we would say sometimes in virology is a fitness advantage in terms of binding these receptors and appearing to be more transmissible. It does not overall look like this variant causes more severe disease. There's been some conflicting data on this, but in general, the concern is more about transmissibility. In the greater London area and beyond, this became the dominant isolate very quickly in the fall. The South African variant is a little bit different, but also involves changes in the spike protein. And the concerns there are about transmissibility, but also about cases identified in South Africa in patients who have previously recovered from COVID-19 and then been reinfected. It appears that they were reinfected with this variant, suggesting that the immunity from the previous infection, natural immunity, was not good enough to protect them from reinfection. Also, other concerns have arisen with regard to susceptibility or the impact on effectiveness of certain vaccines, which I'll talk about in a second. And then in Brazil, there have been a couple of different variants identified. One, by the way, just very similar to the UK variant, but more recently, another that's a little bit different. And there's a lot of interest in this, not a lot known yet. Basically, in Brazil, by the fall of 2020, the majority of Brazilians, based on sero studies, appear to have been exposed to COVID-19. And hospitalizations and deaths, which had peaked, I think, in the spring and early summer, were low or lower. In Manaus, in particular, in the Amazon basin in January of 2021, a really significant uptick in hospitalization was noted. And this is surprising given the results of those earlier sero studies. So there are many questions about why that's happening, including whether or not natural immunity from the spring of 2020 has waned and you have more people getting reinfected because of that, or is it, for example, because of a new variant like this, which may have similar implications to what we're worried about in South Africa. Next slide, please. So again, what are the implications of the variants? And I guess if there's anything that I would hope everybody takes home from this session today, it's that although we clearly need to take variants seriously, I think we also need to be careful not to feed into some of the sort of extreme fears that are being fueled by some of the media coverage around variants, because there's some very important things to sort of keep in mind about what we've already got that should be effective against the variants. And first is that the COVID-19 mitigation basics, they work. We know this, especially masking, physical distancing, and the variants, I think, are a reminder to us that we need to continue to focus on these basic tools. The second major implication of the variants is that they really add a sense of urgency in terms of the efficiency of the vaccine rollout, because less transmission means less viral replication. Less viral replication means fewer opportunities for these typos, right? So fewer opportunities for mutation and viral evolution. And as much as I think all of us have shared various frustrations about the rollout and how it's working and why it isn't faster, we need to remind ourselves on a daily basis that we ended up getting 2 unbelievably effective vaccines out much faster than anybody expected. And, in the news this week, we've got about 10% of Americans with at least 1 dose of COVID-19 vaccine. To me, that's actually a really impressive number. Other implications for the variants, the emergence or the recognition of these variants highlights the importance of active surveillance in terms of molecular epidemiology. Active surveillance meaning going out and looking for these changes so that you have a heads up in terms of what's going on in a community, a state, a country, rather than passive surveillance in epidemiology, which is where you wait for somebody to report something. And the CDC and the states are trying to ramp up active surveillance to the extent possible. Finally, the ability to evaluate the effectiveness of the vaccines we have against the variants is crucial. The ability to adapt the vaccines that we have if need be, and the implications around the potential role of booster doses of vaccine. Next slide. So just a reminder, on the types of COVID vaccines in play, currently we have the 2 mRNA vaccines, Moderna and Pfizer, which I just want to say right off the bat, part of the issue in sort of talking about any other vaccines is that Pfizer and Moderna, the mRNA technology has set the bar extremely high in terms of efficacy. Those vaccines hit it out of the park. Which makes it challenging to sort of appreciate, I think, the benefits and the value of some of the other vaccines that we're probably about to see reach us. Then we have viral vector vaccines. So this is basically taking, in the case of the AstraZeneca vaccine and the J&J vaccine, taking an adenovirus, which is these are the types of viruses that can cause the common cold, but taking a version of an adenovirus that cannot replicate and essentially using it as a transport mechanism for the gene that encodes the S protein, right? So with the mRNA vaccines, you're basically delivering the mRNA recipe for that spike protein. With the adenovirus vector vaccines, you're essentially packaging the DNA so that can also be read as a recipe so that cells can produce the spike protein and elicit immune responses. The viral vector vaccines, by the way, there's an example we already have, which is a very successful Ebola vaccine. Finally, protein-based vaccines. So Novavax, which is soon to apply for FDA review, is a protein-based vaccine where you essentially deliver the S protein itself attached to an adjuvant, which is essentially an irritant that works to accelerate or amplify the immune response. Protein-based vaccines, there are various sort of variations of them, but I just want to say that that's not new technology either. So familiar examples would include the hepatitis B vaccine, one of the most successful vaccines ever developed, as well as Shingrix, also familiar. So moving on, the J&J vaccine, which is next up for FDA review. We are still in the kind of data by press release phase for J&J. The phase 1/2 safety and immunogenicity trial data was published, by the way, in the New England Journal in early January. But the phase 3 trial data is just sort of what we've heard last week from J&J, reporting on, I want to say, like 40,000 people overall, and I'll have to pull up that number separately, but in any case, yeah, so 43,000 people, multiple sites, 72% effective in the US, and that's for, all disease, all symptomatic COVID, 66% effective overall. The reason the overall number is lower is primarily that it was less effective, significantly less effective for symptomatic disease in South Africa. However, it remained highly effective across all sites in preventing severe disease. And I may say this more than once, but I think that's another really sort of key point here. We're looking at things like this vaccine and saying, well, I don't know, Pfizer and Moderna, over 90% effective, so much better. But the most important metric probably for effectiveness or efficacy of these vaccines is preventing hospitalizations and deaths. And in that regard, J&J also looks pretty wonderful. And again, J&J is looking pretty good against the South African lineage, which is important. And I'll just say briefly, I'm not going to talk about AstraZeneca too much because that's actually not close to FDA review in the US, and that's a very complicated vaccine to sort of talk about in terms of data. But the headlines around that, with regard to the South Africans making a decision not to use it, are a little bit misleading in the sense that there's still a lot we don't know. The data upon which that decision was based involved a small trial of 2,000 people who were all pretty young. They couldn't even look at the outcome that we really care about the most, which is this hospitalization and death outcome. So Novavax, again, delivering the spike protein itself associated with an adjuvant. And again, this one, we just got the press release. We'll wait to hear more, but it is really promising. It uses technology that we're familiar with. And the really interesting thing about Novavax is that they conducted the trial after the B.1.1.7 variant had already become dominant in the UK. So that's great because it gives us sort of explicit assurance about the efficacy of this vaccine in the presence of that strain. And the B.1.1.7 variant, by the way, has been identified in well over 30 states in the US now. So, that it's definitely here. Whereas the South African variant has only been identified here on basically a case report basis so far. So again, this looked really good about in terms of the original strain and B.1.1.7. And even in South Africa, by the way, the efficacy was not terrible. And I think it's terrible when you look at Pfizer and Moderna as a comparison, but when you look at, say, a flu shot as a comparison, it's not terrible. Additional trials are underway for Novavax. Next slide. And then this summary table was created by a friend of mine from residency and fellowship. And I think it's great, mainly to just sort of highlight that we've got a bunch of candidates that are looking very promising. And I should say the bigger number is in the dozens. So there are 40 or 50 candidate vaccines in various stages of preparedness for delivery. But these are sort of the heavy hitters that we either have or are probably about to have. And again, when you look at the outcomes that we really, really should be caring about the most, they are all looking very, very good. And I should say also, in terms of Moderna and Pfizer, there's been a lot of work done on those two vaccines, looking at the impact on the South African variant, and essentially looking at T-cell and humoral responses in a laboratory setting. And they are looking very, very good. Part of this is because those vaccines, the efficacy overall is so high that from a virologist point of view, there's wiggle room there, even with variants. And that's going to be a tough thing to talk about in a lot of settings, because those two vaccines are going to still be very hard to deliver in places like South Africa for a number of reasons. But it is good to know. And the other thing is, some of these in this table, some of the numbers are relatively small from a vaccine point of view in terms of trial data, but they're all very consistent in their findings. Some of them, and I should say also for AstraZeneca, the number is actually now larger in terms of data that's been released. But the consistency across all of these for efficacy against severe disease is very reassuring. Next slide. So for the, sorry, and I don't know if we could do questions now related to this topic or move through the rest of these slides and loop back, either way.
I think I'll just wrap up, Cheryl, because this is mostly info that we said. I just wanted to remind folks just a few quick updates that in the governor's press release last week, he reiterated we're really still in anybody left in 1A, but phase 1B, 70 and older. But that given the flow of vaccine, it looks like the state will likely be able to get to the 65 to 69-year-old group by early March. We still have not defined the specifics of these next two bullets, primarily because there's concern that we need to get through those first groups first. Information is on the governor's website, including all the sites. And then just a quick plug again for the equity, the DHHS equity webinar that we're going to hold next Wednesday. We will be not holding this clinical info session next Tuesday. I wrongly said last time it's the same link that you use for this one. That is wrong. So I will copy, or any of my colleagues feel free to copy and put in the link. There's a register in advance, or there's a different Zoom link for this one coming up on the 17th, not the same one as today. We do have other information about asking race and ethnicity. There's actually a live link in this slide set. And then again, just resources, including from US CDC and Maine CDC. So with that, I will stop sharing and move to questions. Anybody want to tee some up?
So I'll just tee a few up. So the one of the questions was, how effective is Moderna preventing hospitalization and death compared to J&J? So Moderna is basically 100% effective on that metric, and J&J looks basically that good, or almost that good as well. And some had questions about the table I shared from Monica. So she's sort of one of the ID docs who's become pretty active on Twitter. And she's also, I have a little bit of a bias here because it's sort of my ancestral home, but UCSF Department of Medicine does their grand rounds every Thursday, and they've been making that available on YouTube. This Thursday, it's going to be all about vaccines and variants, about this topic, and Monica is going to be one of the presenters or co-hosts of that grand round. So I highly recommend that. They are great. Other questions? Any reports in the US of first dose and second dose recipients getting infected? Sure. So we know, we knew from the phase 3 trial data, which really looked at, remember that the endpoint for mild to moderate disease wasn't even officially measured until people were considered fully vaccinated with Pfizer or Moderna. In other words, 14 days after the second dose. Were those vaccines 100% effective at preventing infection? No. But they were in the 90s, which was unbelievably high. So I'm familiar with one or two cases right now that have been seen after the completion of vaccine. It's not surprising based on the trial data. And I think when you see that, by the way, that should not trigger an immediate worry that this is a scary variant. In all likelihood, it's not a scary variant. On the other hand, Maine CDC and states everywhere and the federal CDC are very interested in sequencing these isolates, and we'll learn more with that. Other questions? Let's see. Any further info on how Pfizer and Moderna prevent transmission? I have a lot of feelings about this. I mean, as a sort of a bystander, kind of reading the data and the advice of experts, before COVID, never did we focus so much about the risk of asymptomatic transmission in a person vaccinated for a respiratory pathogen. And even in the original Moderna trial, they swabbed everybody, by the way, between dose 1 and dose 2. And they found that far fewer people in the vaccine group had any asymptomatic carriage than in the placebo group. So that was already kind of initial suggestion that these would be very good at preventing transmission. There has been some more data that has come out since that time supporting it as well. And I want to say that the J&J trial actually built that in a little bit more explicitly. So I think we'll be hearing more from them too. But I think you're going to hear more and more and more that these vaccines do actually prevent transmission in vaccinated individuals or from vaccinated individuals as well. And from that perspective, I fully support the decision that Maine made recently in terms of exempting fully vaccinated individuals from quarantine, at least in non-healthcare settings. So other questions? I'm sorry, I'm kind of scanning the section here.
Question about how many samples does Maine send to check for variants?
So that'll be a question, I think, for Lisa or you. Do you guys know the answer to that?
I believe I have heard them, don't quote me, 0.5%, Amy, is that what I've heard? That there is a regular sending, it's a relatively small number, but on par with other states, what other states have done. There's been talk about ramping that up, but I believe it's 0.5%. Amy is slightly nodding yes.
I think it's, and again, I think everybody agrees that kind of active surveillance is incredibly important. I think it's one piece, right? So you look at that as well as continuing to look at things like your positivity rates, your volume of testing. We all know that things like hospitalization are lagging indicators, but I have to say, I'm encouraged right now by what we're seeing nationally and in Maine in terms of, which way things are headed. And we don't have indications here clinically in Maine in terms of positivity, et cetera, that we're seeing a rise that we might be worried is fueled by variants, for example.
Cheryl, I'm not sure if this is for you or Lisa. Are there any new recommendations regarding screening for healthcare workers who have been fully vaccinated?
I'm happy to take a stab at that if you want. So I think this is getting at kind of, well, what do we, now we've got a lot of healthcare workers are vaccinated. Do we handle them differently? And the state of Maine, again, has made this exemption from quarantine for fully vaccinated individuals, but in conversation between, my health system and CDC, the consensus was we need to operate using the standard of the federal CDC from a regulatory point of view and other points of view. I think that, so we can't exempt those people from quarantine from the perspective of like who enters our buildings in hospitals, for example, right now. There's a lot of interest in which way this is going to go from a federal CDC perspective, and I wouldn't be surprised to see a shift in that at some point over the next month or so. But for now, where I work, we haven't changed anything we do.
And I'll just follow on behind that to say the state has not changed that. So the HAN that was put out a few weeks ago now that did allow exemption was sort of for the public, and it says specifically long-term care and healthcare should still follow federal guidance. So the same.
And we have, by the way, been in an interesting, I think systems all over the country maybe have seen this, like in my world, we make a different, we use federal guidelines in terms of who to test or not test when they're experiencing what are probably reactogenicity symptoms, especially after dose 2. But if somebody's febrile, we're generally testing them. And there've been a couple times when we pulled up a positive through that. But I think that if you look back, probably what we're doing is sort of uncovering something that may be old and asymptomatic. And it's just hard to tease out in terms of, kind of the post-vaccine world. I think some of the things that we're thinking might be a case or maybe not a case, like a relic from the past, essentially.
Great. I'm also just going back on here, Amy. It's a question about, is there consideration of distributing vaccines in a way that's prioritized for geographic need? I would say that, there's multiple factors that go into decision-making about vaccine allocation. It is largely population-based and based on where vaccination sites can get vaccine out quickly, really, again, trying to rapidly distribute vaccine, certainly issues of equity, and there was a statement actually put out by Commissioner Lambrou just yesterday, I think, to all vaccination sites, urging them to follow requirements around residency and other phasing requirements, as well as new recommendations and requests to look at ways to apply an equity filter and efforts to increase equitable distribution of vaccine. So not directly, no, but certainly one of the factors in complex decision-making. There was also a question about, is that table, Cheryl, your fantastic table in the slides, available online? I don't know, I think you got it directly from your colleague. Our slides are posted online after these sessions, so you could get it from that. But do you have other knowledge, Cheryl, of where that's shared? Or
Monica is getting pretty active on Twitter these days, and it is actually accessible that way. She's working on updating it. And again, I would encourage, she's co-hosting Ground Rounds at UCSF this Thursday, which will be available on YouTube as well. And those Ground Rounds are incredibly good in general. And they're either posted Thursday evening or Friday for a review. And I would highly encourage that, which is great.
Great, thank you. And then I'm seeing the last one here. The vaccine fact sheet says it's not FDA approved. Are they working on full FDA approval? And my understanding is yes. So these vaccines have been authorized through the emergency use authorization in order to get them out as quickly as possible in the face of this deadly pandemic. But that data will continue to be accumulated. And my understanding, Cheryl or others, correct me if I'm wrong, is that the manufacturers typically go on to seek full FDA approval over time when they reach the time frame, which is typically, I think, a median of 6 months post follow-up versus 60 days for the EUA, I believe. Okay. So we are at the end of the hour, or half hour, I should say. Seeing one more, are we expecting new CDC guidance for long-term care as far as vaccines and quarantine? There have been updates about long-term care and testing. We have our 11 o'clock long-term care medical directors call today. Anyone feel free to email me if you're not on that list, lisa.letourneau@maine.gov, but no new guidance around quarantine and vaccine, as mentioned a few minutes ago, until CMS and federal officials change their guidance. So thank you all. Again, thank you so much, Cheryl. Cheryl is not able to be with us on Friday, but Dr. Steers is. For anybody who has colleagues who join on the Friday sessions, we'll continue the discussion about these important topics. And remember, no session next Tuesday, the 16th. Please join us on the 17th. I did put the login info there, and I'll make sure that's more clear on the slide set once we post that. We'll be back on the 23rd, and I believe Dr. Penoyer will be joining us talking about issues of screening for allergy and how to handle that with particularly the mRNA vaccines. Thank you so much. Take care. Bye-bye.